Yes, you are audible.
Okay, super. So, hello everyone. I welcome you all for today evening's session about the new module about the geriatric rehabilitation. And today we are going to understand about the cardiopulmonary rehabilitation, which is the most one of the most common rehabilitation services what we provide in the geriatric population. So, does anyone know what is cardiopulmonary rehabilitation? First of all, anyone, like what do you do in that? What is it about? Okay,
Cardiac
so
rehabilitation
yes,
is a rehabilitation of heart and lung systems. Uh,
perfect. Okay.
yeah, like literally does that. But to better phrase it, it is rehabilitation of heart and lung system of patients who are having problems with their cardiac and pulmonary system, basically.
Perf- Perfect. Anyone else? Cardiovascular system management, chest clearance. Yes, chest clearance is one of the techniques, but I'm talking about the overall rehabilitation services. So, cardiac and pulmonary rehabilitation or the cardiopulmonary rehabilitation is a supervised exercise program that involves education, nutritional counseling, stress management, smoking cessation, other lifestyle changes which are designed to prevent or reverse the progression of cardiac or pulmonary diseases. The goal of the cardiac and pulmonary rehabilitation includes establishing an individualized plan to recondition your heart and lungs to help you regain the strength, prevent your condition from worsening, reduce the risk of future heart or lung problems, and improve the overall functional capacity, health, and quality of life. Is everyone clear and everyone with me?
Yes.
Okay. So, in short, I'm just telling for an example, majorly we get these patients, specifically, these are majorly age related problems. People who have ischemic heart disease, people who have coronary artery disease, people who have heart failure. So, these patients usually are majorly fall into the geriatric population, and that has a low overall compromise over the quality of life. Their activities are restricted, the exercise tolerance is reduced, so that reduction in the activities is because primarily because of heart and lung. And how to rehabilitate, so it could be because of post surgical rehabilitation, or it could be just medically management conditions also. So any conditions where you really focus on improving the heart and the lung strength, their capacity, their exercise tolerance, is called as cardiac pulmonary rehabilitation. With this rehabilitation, we usually help to get the patient back to the normal levels what they were before, and improving their overall status. So, which conditions benefits from cardiopulmonary rehabilitation? In the cardiac conditions, one is person who have PTCA or stenting, which is the most common. Second is congestive heart failure. Third is coronary artery bypass, graft, heart attack or ischemic heart disease, heart valve replacement, post heart transplant, or stable angina pectoris. And any more also, like congenital heart diseases also. Pulmonary condition, the most common is COPD, persistent asthma, bronchiectasis, cystic fibrosis, interstitial fibrosis or ILD conditions, occupational or environmental lung diseases, and a connective tissue disorders. These are the major conditions who get benefited from cardiopulmonary rehabilitation. Everyone clear?
Yes.
Yes. Yes.
Okay. So, first of all, before going to the assessment, we'll be discussing few conditions which are most commonly seen in geriatric population. First is something called as ischemic heart disease. Can anyone tell me what is ischemic heart disease?
Lack of blood flow and oxygen to the heart.
Okay, what could be the reason for that? Perfect.
Athero- Atherosclerosis.
Yes. Atherosclerosis is one of the correct reason. So atherosclerosis. So as with the age, the people will have more comorbidities. Again, there are lifestyle changes. Obviously, stress will be there with them. But with the age, your arteries, your arterial wall will become very thick. There will be increase in the lateral pressure. That lateral pressure will increase their hypertension. When there is increase in the hypertension, there is a constant load which is creating inside the arteries. The preload as well as the afterload will be more. When there is an increase in the pre and the afterload, the heart has to work more. Also, with atherosclerosis, with the age, as we know, when there is too much of cholesterol which is in the body, the free fatty acid which is flowing in our bloods will start getting accumulated inside the arterial walls. Once they start getting sticking to the arterial wall, the free fatty acid will be covered with a thick plaque. What is a thick plaque? It's basically like a covering, it's like a capsule. When the capsule is going inside the artery, the blood flow is restricted. When there is a restriction of the blood flow to the heart, as we know that heart pumps the blood to the entire body, but also our own heart has its own blood flow system. That blood flow system is being supplied by the coronary arteries. So the coronary arteries, when these arteries gets blocked and the blood is not flowing properly to the heart, that leads to ischemic heart disease or IHD. Very common. When there is ischemic heart disease, obviously that particular area of the heart will not get the blood. When that is not getting the blood, the functions will not happen, and when the functions is not happen, then the symptoms start arising. Chest pain, persistent palpitations, sudden sweating, breathing difficulties, reduction in the exercise capacity. Person cannot walk, stand for a long time. They feel very breathless. For them, certain activities also become very tiring. So these are the most common symptoms what to be come across in every patient to patient. Is everyone clear? Any difficulties?
Clear.
Okay. So one is ischemic heart disease. Second is coronary artery disease. What is coronary artery disease?
It's
What
the
is a
same
coronary?
like atherosclerotic plaques on the inside the arterial wall of coronary arteries, and that leads to,
Exactly. Yes,
yeah.
correct. So that is one of the conditions. So can anyone explain me what is coronary circulation in the heart? We know the blood circulation in our body, but can anyone tell me what is the coronary circulation of the heart before going ahead? Because that is very important.
As far as I know, coronary circulation is like circle of Willis around the heart, and
No, circle of Willis is in the brain. Sorry, you're getting confused. What is the coronary circulation?
Ma'am, it's a blood circulation around the muscle, I mean, heart muscles.
Yes, so which are the what how will you describe like where does this coronary circulation come from? Which are the different type of coronary arteries? I need the details about the anatomy part of the cardiac system. If we don't know that, how can we directly jump to rehabilitation? Okay. So basically, as we know that our aorta, which is a major artery which supplies the blood to our entire body, that aorta, from the aorta, there is something called as coronary sinus. The sinus is basically an opening. From that opening, we have two major arteries coming inside the heart. One is the right main coronary artery and another is the left main coronary artery. In right main coronary artery, we have two branches again. One we have the marginal artery, another we have the posterior descending artery. For the left main coronary artery, we have again two branches. One is the left anterior descending artery and the circumflex artery. Okay, so when these main arteries keep dividing, they keep supplying to the different parts of heart. So the major left ventricle is majorly supplied from the left anterior descending artery. Okay, your left atrium is supplied from the circumflex artery. Your right atrium is supplied from the major posterior descending artery, and your right ventricle is supplied from the marginal artery. So whenever any of the coronary arteries is blocked, that particular area of the heart will not get the blood. Imagine, just take an example of if your left main coronary artery is being blocked because of atherosclerosis. Obviously, your entire left side will not get the blood supply. If the left is not getting the blood supply, it will not pump the blood to the aorta, and your overall stroke volume and your cardiac output will be reduced. Your muscles, your peripheral muscles will not get the blood. There will be a lot of tiredness, fatigue, sudden chest pain, and also angina. That chest pain is also called as angina. So this is how we have to understand which part of the heart is affected, what will be the symptoms, and what will be the person coming with the picture. Everyone clear?
Yes.
Yes.
Okay.
Yes, ma'am,
So
clear.
can anyone tell me what is congestive heart failure? Until we don't know the conditions, we will not go ahead. I would want everyone to understand the condition, understand the pathophysiology, and then go to the assessment part. What is congestive heart failure?
Backflow of blood because of the pulmonary artery.
Okay, that's one of the parts of it, but I want the more details about the same. Okay, no problem. So whenever, as we know that our heart has its own blood flow and it supplies the blood to the entire body. When there is a mismatch between the demand and the supply of the blood of the heart, the functions of the blood, the functions of the heart is compromised. When the functions of the heart is compromised, that leads to the heart failure. Imagine our body's demand for the blood supply is 100%, and your heart is not able to supply that much blood. Okay, so the supply is 50%. So there is 50% extra load on the heart, and that load on the heart will not be able to be compromised, and that is called as heart failure. Means the heart is unable to pump the 100% of blood to the entire body. Why? How does heart failure happen? It could happen because of any reason. Could be because of ischemic heart disease, coronary artery disease, atherosclerosis, or any valve ruptures, or any electrical problem of the heart. These are the different factors where the heart failure can happen. But there are two types of, there are classification. One is a right heart failure, one is a left heart failure. What is the right heart failure? Means when the right side of the blood is not able to pump the blood to the pulmonary artery towards the lungs, there will be lot of backflow of the blood from the right ventricle to the right atrium and the superior vena cavas and inferior vena cavas. In such conditions, the major symptoms the patient will have is too much of breathless, bilateral edemas, there will be tiredness, fatigue. Okay, in the left ventricular heart failure or the left side heart failure, what happens? The aorta is not throw the left ventricle is not throwing the blood to the aorta. So because of that, there will be increase in the back pressure from the left ventricle to the left atrium to the pulmonary vein and the pulmonary artery. So your lungs will be extremely congested. There will be a lot of fluid inside the lungs. That will make it very difficult for the patient to breathe. There will be cyanosis, there will be sudden reduction in the saturation, and again tiredness and fatigue and reduce exercise tolerance. When these system or pathophysiology happens, that leads to heart failure. Is everyone with me? Any difficulties?
No.
Ma'am,
Okay.
crackling breathing sounds
Yeah.
occurs in left ventricle heart failure, right?
Okay. So crackle sounds can happen into many conditions. It could happen because of pleural load. It could happen because of ILD also. So there are many different conditions. But before that, we need to understand the pathophysiology. Okay.
Mm-hmm. Okay. Okay. Thank
Yeah.
you.
No problem. So how will we suggest that the person has the heart failure? So when you do a 2D echo, there is something called as ejection fraction. So ejection fraction tells us how the left ventricle is functioning well. So normally in our body, the ejection fraction is around 55 to 60%. Anything between 40 to 55% is a mild heart failure. Anything between 30 to 40 is a moderate heart failure. Anything less than 30 is a severe heart failure. Anything less than 20% is a very severe heart failure. So it depends on the condition what the patient comes to you. Your assessment, your rehabilitation services will automatically change. Everyone clear with IHD, coronary artery disease, and heart failure? Any difficulties yet? Okay. So how will you manage? So sometimes when the patient is coming with chest pain and the patient has myocardial infarction, so if there are when they do 2D echo, when they do angiography, that's when they come to know that how many arteries have been blocked. If it is just one artery, it is usually managed with stenting. If it is more than 70-80%, if it is only 20-30%, if it's only 20-30%, it could be medically managed. If it is more than 2 to 3 arteries with 80 to 90% of blockages, the next medical management should be a bypass surgery. Okay, so depends on what is the status at the 2D echo and angiography and the X-ray. The cardiologist will decide what has to be done. Sometimes if it is only 30-40% and 2-3 of the vessels, they usually do 2-3 stents. But if it is more than 80-90%, bypass surgery is the most common surgery which has to be elected. Okay. Everyone clear how to choose and when to choose? This is not our job, but we should be aware about the same.
Yes.
Okay. So whenever the CABG operation is done, as we know, it's a bypass grafting. So where are the major grafts taken from the body? Does anyone know this? Which are the grafts which are mainly taken during a CABG operation?
Leg, popliteal, something.
Popliteal? No.
The saphenous vein.
Saphenous vein? Yes, perfect. Why saphenous vein?
It's easier to
It's a
harvest
long,
that way.
It is?
it's a long vein, like a long
It is
distance.
the longest
Yeah,
vein.
it's good length.
Okay. There are many other veins in our body and arteries which have good length. Any other reason? So do veins have this? So how what is the diameter? Is the artery has a shorter diameter or vein has a shorter diameter?
The
Again,
arteries have a
anatomy.
smaller diameter.
I cannot hear you. What?
Arteries have a smaller diameter.
Exactly. So that's why saphenous vein is taken because the diameter is larger. If the diameter is larger, more blood flow, right? That is what we want, right? So saphenous vein is the most superficial vein in our body. Second, its diameter is little larger as compared to the arteries. And third, it has valves. Okay, so if they replace the saphenous vein in an opposite direction, these valves will not work and there will be a good blood flow, which is going when they bypass the blockages. That is the first thing. Any other arteries they take? Though they take only saphenous vein?
Radial
In
artery.
the
Yes,
artery,
radial artery. Yes, radial artery again very commonly accessible artery, and it is perfect to be taken from that area. Anyone else? Any other options?
internal mammary artery.
Exactly. Left and right internal mammary artery, Rima and Lima. These are the most common and the most easiest arteries to be taken because they are inside the chest only. They just have to be taken, they have to be turned, and they have to be grafted. But when they want to take saphenous vein and radial artery, they have to actually cut and open the skin and take the artery sample from there or the vein sample from there. So the most common depends on how many blockages are there. They usually take Lima and Rima. If they need additional kind of like additional grafts also, they take from saphenous vein or radial artery. Everyone clear? Any difficulties?
Yeah, ma'am.
Can you please
So we
repeat what helps them decide whether Lima Rima has to be taken or saphenous vein has to be taken depending on the
uh,
severity of blockage.
No,
Is it?
yes, depends on how many blockages are there. Suppose if they have 4 to 5 blockages, majorly people have 3 grafts or 3 to 4 grafts. So Lima and
Okay.
Rima is taken into 2 grafts. So they need another graft also, right? So that another
Right.
graft will be taken from saphenous vein or radial artery. Depends
So
on
saphenous
how
vein is
many.
not the first choice.
No, it is yet never the first choice. They usually start taking from inside the thorax only. Suppose many
Oh,
people have Lima Rima blockages also. So if Lima Rima is also blockage and the artery condition is not good, then they have to take for saphenous vein.
oh, okay. Okay.
So
Fine.
when they
So,
open the, yeah,
but artery, as you said, is much narrower than the vein. And it might be, like, as you said, um, more blocked compared to the vein.
correct. Yes.
Okay, so
Yeah.
then they go for the saphenous vein. But what if they have 3 to 4 blockages and Lima Rima is also not in a good condition?
So what they do, they take the entire saphenous vein, they cut according to the graphs what they have to take, like 5 centimeter, 4 centimeter. If that is also not enough, then they take radial artery also.
Okay. And how do they seal back that cut down big part of the vein? They stitch it back together.
Yes, they stitch it back together with the help of the Poprine 0.5. There are threads which are available in the market, which are soluble inside the body. Those are the wires they usually take to do the sutures.
Wow. Interesting.
Yeah.
Thank you.
No problem. So this all suggestion and decision has to be taken on the table when the surgeon opens the patient. Okay. This is again not our thing, but again, there are many complications which happen after the surgery, which a physiotherapist has to look into the picture. So if you don't have knowledge about it, you will never understand this. Everyone clear with the cardiac condition? These are the most common conditions what we see in geriatric population. Yes, no?
Yes.
Great. Now
Yes.
we'll go to something called as pulmonary condition. What is COPD, first of all?
Chronic obstructive pulmonary disease.
Okay, can you please, yeah, can you please elaborate on that?
I hope someone else can.
Definitely, no worries. Whoever knows, please elaborate so that everyone can brush up their knowledge about the same, and then we can go ahead the rehabilitation part.
It's a lung disease that blocks the airflow.
A lack of perfusion of the oxygen carrying capacity in the alveoli, maybe from things like smoking, perhaps. Could that be one? But
Yes, very good. Amazing. Anyone else?
It's chronic
You
bronchitis,
in
emphysema.
there.
It has two components actually. One is chronic bronchitis and emphysema.
Hmm. Another one is?
Emphysema, chronic
Yes,
bronchitis and
and then
emphysema.
emphysema. Okay, perfect. So now, first we'll start with chronic bronchitis and then we'll go with emphysema. So now, what is chronic bronchitis? What are the symptoms and how does it happen?
smoking, perhaps, clogging, so blocking the ability of the alveoli to take on the oxygen. The hemoglobin carrying capacity of the red blood cells affected. It possibly could be something from memory.
Okay, yes, that is one of the parts. But can anyone define me what is chronic bronchitis before going to the factors?
Bronchi is inflamed, ma'am.
Okay, yes, and
Bronchioles or bronchus.
okay, so yes, everyone is going on the correct path, but let's go into the more depth and the more precise definition. So, chronic bronchitis is basically it's a condition where the person has chronic inflammation of the bronchus and extreme cough production for more than 3 months for consecutive 2 years is the definition of chronic bronchitis. Okay, so now itis means inflammation. So, whenever there is inflammation in our respiratory tract, or bronchopulmonary tree. Okay, there is the first reaction will be inflammation. When there is inflammation, there will be inflammatory markers there. There will be increase in the production of the mucus. When there is increase in production of the mucus, your entire airway tract will be narrowed because of too much of mucus. The air going inside will be also less. Air going outside will also be less. And when there is less oxygen exchange in the alveolar and the blood, there will be less saturation levels, and the blood will not have good amount of the oxygenated blood, and the amount of the air as during the expiration will not be thrown outside, and that is why the person will have too much obstruction, and because of obstruction the person will not be able to breathe. So which are the most common factors of chronic bronchitis? One is smoking, one is environmental pollutants, one is family history, other could be any chemical inhalation. So these are the most common factors which we encounter. Okay. And smoking is one of the important. So many of the geriatric population who have been smoking since more than 40, 50 years will have chances of developing chronic bronchitis. Everyone clear with the first part yet?
Yes.
Okay, now we'll go to emphysema. Emphysema basically is as it's a permanent damage of the terminal bronchioles and the alveolar sacs where the oxygen exchange will not happen. So emphysema, what happens is basically the entire respiratory bronchioles or the entire support of the respiratory bronchioles, there will be a damage inside the entire sheet. When the sheet is damaged, the alveolar sacs will lose its shape. When there is losing of shape, how much ever oxygen is coming there, there will be less exchange. When there is less exchange, the blood will not get the oxygen. There will cause desaturation, and also there will be a permanent damage to the entire terminal bronchioles and the respiratory bronchioles, which also causes desaturation. So most common factors which the person comes into picture for emphysema is again smoking. It could be antitrypsin 1 deficiency. So what is antitrypsin? It's basically it's a one of the proteins which helps to form the elastase. The elastase, which is a protein which is there inside the sheet of the lungs, it is forming. When these antitrypsin 1 is deficient, these protease and elastic enzymes will not be formed, and the structure of the entire respiratory or the terminal bronchiole will be lost, and the saturation will not happen. And then there are other family history and environmental causes, too much of pollution, chemical inhalants. So these are the major factors of chronic bronchitis and emphysema. Everyone clear with this first?
Yes.
Ma'am,
Yes.
can you please repeat emphysema, please?
No problem, don't worry. So what is emphysema? Emphysema is basically it's a damage. It's a permanent damage. Always remember, it's a permanent damage of the walls of the respiratory and the terminal bronchioles, where the alveolar sacs and the alveolus will lose their shape. When there is a losing of shape, there will be no exchange of oxygen between the alveolar sacs and the blood vessels. The blood will not get good amount of oxygen, and that can cause desaturation. Clear?
Yes, thank you, ma'am.
No problem. So again, so we have understood the pathophysiology. Now we'll come to the symptoms. Obviously, when there is no oxygen, the person will feel breathless, they will feel dyspnea, they will feel palpitations, they will feel short of breath, there will be heaviness on the chest, the muscles will be very fatigued faster, they will not be able to walk, stand also, because when there is desaturation, the blood is not getting enough oxygen and the muscles are not getting enough oxygen. That can lead to again anaerobic respiration. Whenever there is anaerobic metabolism, too much of lactic acid production, and that will lead to faster fatigue, and the overall exercise tolerance, exercise capacity, quality of life will be reduced. And some patients who are at the severe stage of COPD will need constant oxygen support, which is also called as long-term O2 therapy. Clear?
Yes.
Yeah.
Yeah, ma'am.
So now the next common condition is bronchiectasis. What is bronchiectasis?
Dilatation of bronchioles.
Perfect. Very good. Perfect. So basically, bronchiectasis is a permanent structural dilatation of the bronchioles where there is too much of widening of the bronchioles. When there is widening of the bronchioles, there will be increase in the inflammation. When there is inflammation, again, there is too much of mucus. And in such conditions, when there is dilatation of the bronchioles, the mucus throwing, the cilia movements will be disturbed and the mucus will not be thrown outside and there will be too much of mucus retention. So the classical symptom in bronchiectasis is too much of cough production or sputum production. Okay. And if the sputum is there inside your lungs for a very long time, it can be infective. And that infective mucus will again cause too much of greenish yellowish sputum, shortness of breath, tiredness, and fatigue. Everyone clear with bronchiectasis?
Yes.
Yeah. Next common is again ILD. Okay, ILD is not commonly seen in, it's majorly seen in all populations, but most commonly affected in geriatric population. What is ILD? It's an interstitial lung disease. So it's again an umbrella term in that there are many ILD types. It could be NSIP, it could be PEP type P, it could be idiopathic ILD. So there are different types of ILD which are present. Most commonly, what we see is a non-specific interstitial pneumonitis, which is called as NSIP. Okay, how does ILD happen? Major cause is idiopathic. Second is genetic. Third, it could be because of any occupation, okay, like occupational lung diseases, or it could be because of any infective pathology or any connective tissue disorders. So in ILD, what happens is our lung parenchyma, the lung parenchyma. It's a lung parenchyma or the interstitial space. What is interstitial space? A space which is between our alveolar sac and the blood vessel. That thin layer, that interstitial space will be fibrosed. Okay. Fibrosed means it will become very thick. When there is thickening of the entire interstitial space, the oxygen will not be able to penetrate from the alveolar sac to the blood vessel. Imagine how much ever oxygen the person has inside the lung. If it is not being able to diffuse to the other side, the oxygen will not go to the blood and there will be desaturation. So, interstitial lung disease is a restrictive condition and COPD is an obstructive condition. Everyone clear?
Yes.
Okay. So again, what are the symptoms? Again, breathlessness, fatigue, reduced exercise tolerance. That can lead to cyanosis and clubbing and other symptoms like palpitations also if the ILD is very severe. Again, once you know all these conditions, it is very easier for you to start assessing the patient and start rehabilitation. Now we are going to understand about the assessment. Okay. So once the patient comes to you, if the patient is coming to you in your clinic or the patient is in the hospital, IPD, ICU, wherever the patient is admitted, the assessment is very important. So we'll take an example of a patient with ischemic heart disease because of the coronary artery disease. So first thing, whenever you go for assessment, you have to always first check for the vitals. Vitals may the major thing is respiratory rate, heart rate, blood pressure, saturation, RP. What is RP? Anyone can explain?
Resting perceived exertion
It's
or
it's
rapid perceived I don't know.
no. It's a rate of perceived exertion. Okay. So basically, it tells you how tired the patient is or how exhausted the patient is. Okay. Because as you know, in cardiac and lung conditions, oxygen is not reaching well. The patient will always be very exhausted. Okay. So these are the major vital assessment what you have to do. Second, higher mental function. Many patients who come to ICU, IPD will come into syncope. Suddenly, the heart supply is closed off. Person goes for syncope. So you have to see whether the person is alert, conscious, or not conscious. If it is, many patients, because of the heart attack, can also lead to stroke. Okay. So you have to check their alertness, you have to check their higher mental functions and the cranial nerve assessment. Next is musculoskeletal. Musculoskeletal, basically, you have to check for the range of motion, tightness, any fractures, or any other injuries are there in any particular joint is what you have to check. Also the muscle strength. If they are, hello, am I not audible? Hello.
You are audible, ma'am.
Okay.
I can hear. Yeah.
Okay, thank you. So if any of the person who don't have good muscular strength or they don't have good flexibility, it will be very difficult for such patients to do cardiopulmonary rehabilitation. So before, always make sure that you check the musculoskeletal system properly. Make sure that they have good flexibility to go ahead with the exercise. Then is neurological. If the patient is not conscious, if the patient is confused and disoriented, how will you make them exercise, right? So those are the neurological examination is what is also you have to do. Circulatory examination. So circulatory examination basically means you have to see whether the hands or legs are getting good blood or not. So how will you palpate? In our hand, we'll palpate radial artery. In our legs, we'll palpate dorsalis pedis artery, okay, or posterior tibial artery. With the good assessment of the arteries, you will understand, are the peripheral vessels getting good blood? If you suddenly start exercising and the peripheral vessels are not getting good blood, that can lead to overuse of the muscles and that can lead to fatigue faster. And also, in some conditions, if the blood flow is totally stopped, can also lead to necrosis. Okay.
Ma'am, now.
Then, as
You are
yes.
not audible.
Hello, am I audible now?
Yeah, the previous sentences which you told are not audible, ma'am.
Okay. So I'm at the last thing which I mentioned was circulatory examination. In circulatory examination, what you have to do is basically you have to check for their hand and leg circulation. So for the upper body, you will check for radial artery. For lower body, you will check for dorsalis pedis artery or posterior tibial artery. In that, you will come to know whether the blood flow is good to the peripherals or not. If the blood flow is weak or if the blood flow is not good, you have to first secure the circulation in the peripheral vessels and then only start with exercising. Before knowing anything, you suddenly start exercising can lead to necrosis also. Next is BMI or body fat percentage. So many patients who have cardiac or pulmonary diseases will have some kind of cholesterol or will have some kind of metabolic disorders. If you know their BMI, you will understand the risk factor and you will also understand how the patient, how much patient has the muscle mass or the body fat mass. According to that, it will be easier for you to start the rehabilitation because the major lifestyle changes what we do in heart condition or pulmonary condition is weight loss. Okay, so with the help of BMI and body fat percentage, we will understand whether the person is obese, overweight, or normal weight. Next is blood values and investigations. Very important. So if the patient has undergone has myocardial infarction, the first thing what you have to do, or the first thing you have to check is their cardiac biomarkers. Why cardiac biomarkers is important for a physiotherapist to see? What is cardiac biomarkers, first of all?
Cardiac risk
C-react
markers like HSCRP and homocysteine that can cause sudden heart attack or something like that if we are
No,
exercising too much.
not really. No, that's not the correct answer. Anyone else? So cardiac biomarkers are the markers which are released inside your blood when the person has any cardiac issue, okay, or it has any heart attack. Okay, so when the person has heart attack, these biomarkers are released inside the blood, and when the blood test come, these biomarkers will be high. That's when how we confirm that the person had myocardial infarction. You also have to check their cholesterol level, lipid profile, renal profile, their liver profile, their D3 calcium levels, all the blood values have to be properly thoroughly checked. You also have to check their PT-INR ratio. You have to check their anti-pro-BNP values to see whether what is the current condition of the heart. For investigations, you have to check for ECG, ABG, PFT. These are the major 2D echoes and also coronary angiography. Okay, once these investigations are seen, blood values are seen, then only you have to go ahead for the further assessment or exercise assessment or exercise testing. Everyone clear till now?
Ma'am, these
Yes.
biomarkers contain of troponin and
Yeah,
Another
troponin
common.
I, troponin T, creatinine phosphokinase, MB. Then they have lactase dehydrogenase. They have aspartate dehydrogenase. There are many biomarkers which are available in order to check the myocardial infarction. So most sensitive is troponin I. Then is the risk factor. Risk factor, so basically when a patient comes to you, we have to stratify, right? Is the patient low risk? Is the patient medium risk, moderate or high risk? So how will you do this risk factor assessment? You have to check their age, you have to check their sex, you have to check their comorbidities, you have to check their physical activity history, and you have to check the blood values. According to that, if only one or two is positive, it is low. If it is more than three, four positive, it is moderate. If all are positive, it is a high risk. So for high risk patient, before going to exercise testing, you have to take the permission from the cardiologist or the cardiac physician. Before the permission is not taken, you cannot do any exercise testing because it can be fatal and the person can immediately die on spot. If it's a low risk, you can definitely go ahead with exercise testing. If it's a moderate risk, again, keep the cardiac physician in the loop. Clear?
Yes.
Yeah.
Yeah. So now we have to do exercise testing, which is the most important assessment of the cardiopulmonary rehabilitation. So if you have, first of all, when you want to check the functional activity status, you have to do 2-minute walk test or 6-minute walk test. If you want to check the proper exercise testing, there are two types of testing. One is maximal testing and one is submaximal testing. Maximal testing has different tests like Bruce protocol, which is a gold standard test, which has to be done with the help of the oxygen support, with the help of the VO2 max, where we understand the entire testing. And there are other submaximal testing which are available, like Howard step test, then few cycle tests which are there. Okay, so these are the testing which has to be done in the proper setup where there is a constant oxygen supply, when there is a constant emergency team which is there. If the patient has any complications while doing the testing, it can be easily rectified, and it has to be taken the permission from the cardiac physician. Before taking all these things, you are not supposed to do any exercise testing. Everyone clear?
Yes.
So once you do all this assessment, you will always understand what is the level of the patient's status, or what is the patient's VO2 max, or what is the patient's exercise capacity. After that, you have to create a goal, or you have to create a program which is individualized, tailored for the patient to patient population according to their symptoms. Okay, and that for heart patients is called as cardiac rehabilitation, and for the pulmonary patients is called as pulmonary rehabilitation. First, we'll start with the cardiac rehabilitation. So according to the AHA or AACVPR guidelines, cardiac rehabilitation is a multidisciplinary secondary prevention treatment modality that reduces the mortality, morbidity among the patients with coronary heart disease, improves the symptoms, functional capacity, metabolic status, depression, and health-related quality of life. The AHN AACVPR recognizes all the cardiac rehabilitation and secondary prevention programs should contain specific core components, such as cardiovascular risk reduction, healthy behaviors, compliance with the behaviors, reduce disability, and promote the active lifestyle for the patients. So nowadays, in major of the countries, or specifically in India, whenever there is a heart attack, our family members are very protective. Our family members do not let the patient do anything. They tell that you please rest, nothing you have to do. There will be increased load on the heart, but that is actually making the patient more dependent, that will reduce their active lifestyle. So this change has to be done, and this cardiac rehabilitation program will help to make that change and make the patient more independent. So there are few set of core components of the cardiac rehabilitation. First is patient assessment, second is nutritional counseling, third is weight management, lipid management, diabetes management, exercise training, physical activity, blood pressure management, and tobacco cessation. So as a physiotherapist and occupational therapist, our main aim is exercise training and physical activity. So don't think that cardiac rehabilitation is only exercise. It has so many components which has to be addressed, which has to be looked into picture. We have to speak with all the team members to decide the program. Okay, if you're doing exercises for them, nutrition is important. If the patient is overweight, you have to first of all manage the weight with the help of nutrition so that the cholesterol levels and the lipid profile is coming into the picture and the exercises are getting better. So every component has to be addressed, every component has to be listed, and you have to make a good cardiac rehabilitation team where all the doctors are working together for the holistic approach for the patient. Clear?
Yes.
Okay. So once the assessments and the components have been ticked, then you have to start with the cardiac rehabilitation. So cardiac rehabilitation usually is in 4 phases or 3 phases, depends on which guidelines you are following. Phase 1 is inpatient. Inpatient means when the patient is getting admitted inside the hospital. It could be ICU or it could be IPD. Okay, it could be an acute. So phase 1 is specifically acute phase of cardiac rehabilitation. Second phase is early outpatient, when the patient is getting discharged, okay, is going to home or is coming to your clinic. Phase 3, when the patient is coming into the maintenance cardiac rehabilitation. And phase 4 is the last, where the patient is now starting to go to the community for the work and getting back to its original job or the original level of the physical activity. So these are the 4 phases of rehabilitation. You have to see which of the rehabilitation phase your patient falls into picture. So phase 1. Phase 1 rehabilitation relates to the period of hospitalization following an acute cardiac event. The duration of this phase may vary depends on the initial diagnosis, severity. Usually it is from 1 week of acute event or post-operative. Imagine a patient has PTCA, your phase 1 will only be for 2 to 5 days. If the patient has myocardial infarction, okay, it is 7 days. If the patient has CABG, it is 10 days. So it depends on the condition, your phase 1 will change. In phase 1, basically, you have to make sure that there is no post surgery complications. The patient is able to actively breathe, able to do all the activities of upper limb and lower limb on its own. Patient should be able to sitting, standing, and walking on its own. And if the patient is fit, they can also start with cycling and stair climbing. So this is what you have to majorly achieve in phase 1. Depends on patient to patient. Some patient will have a late phase 1 or the longer phase 1. Some patients will also cover all these activities in 5 days. Depends on their condition and the medical management. In phase 2 rehabilitation, it is usually post-discharge periods, which is typically for 4 to 6 weeks. It focuses on the health education, starting of the physical activity, where the intensity of the exercises will be definitely more than phase 1. Okay, imagine in phase 1, your intensity of exercise is a mild intensity, around 30 to 40% of the heart rate max. In phase 2, it should be between 40 to 50%. Okay, so the intensity should be more, the repetition should be more, and the exercises should be more complex. And these exercises can be done at outpatient, which is in your clinic, or it could be home based also. In phase 3, it is a major exercise phase where there is major strengthening, major endurance training. In this phase, it usually goes from 6 weeks to 12 weeks. This is a phase where the patient is extremely medically fit, medically managed well, and the patient's strength is always better, and they are outside the risk factor. In this, you have to totally focus on proper strength training of upper limb, lower limb, where the strength training has to be done 3 to 4 times a week, and endurance training has to be done 1 to 2 times a week according to ACSM guidelines. Okay, in such conditions, your strength for training for upper limb, lower limb has to be done, and also for core and back strengthening has to be done. In phase 4 specifically, it will be more of maintenance, where whatever you have done in phase 3 has to be progressed and has to be taught to the patient. And the patient will come to you maybe once or twice in a month to learn the exercise and do the progression. And at this stage, the person will start going back to its office or back to its pre event of their problem. And that's when the patient will start coming to the community better and will be more fit with better lifestyle, better health, and better quality of life. Everyone clear till all the 4 stages or 4 phases of cardiac rehabilitation?
Yeah, ma'am.
Okay. And there is one part of resistance training which you have to very clearly remember. Always, whenever you're doing strength training in phase 3 or phase 4, always there has to be 10 to 15 repetitions and different 8 to 10 exercises for upper body or lower body. Every week, you have to increase 1 kg for upper body and 3 to 5 kgs for lower body. Also, make sure whenever you're doing any set of exercises in cardiac patients, the rate of perceived exertion should never cross more than 15. So rate of perceived exertion is a scale which is from 6 to 20. The rate should never cross 15 always. If you feel that the patient's rate of perceived exertion is crossing 15, you have to stop the exercises immediately. And also, while doing any exercises, Valsalva maneuver should be avoided. When there is a breath holding, the blood circulation will be halted and there will be more fatigue and tiredness. Everyone clear? We discussed about all the cardiac conditions. We've discussed about the components of cardiac rehabilitation. We discussed the 4 phases of cardiac rehabilitation and which patients how will come into the picture and which
Uh, uh,
patients will be ben. Yes.
do you think
Ma'am,
you can share your screen like from phase 1, phase 2, phase 3? Just like just for like a 5 seconds like each. Or it's yeah.
This is phase 1. This is phase 2. This is phase 3. This is phase 4 and resistance training.
It just phase 3 1 minute for just yeah. Yeah. Thank you, ma'am.
No problem.
ma'am, can you please explain Valsalva maneuver in brief?
Okay, so what is Valsalva maneuver? It's a maneuver. It's a basically a technique where majorly you might have seen, right, when you go to gym. So many people who lift very heavy weight, more than 150, 200 kilos, they usually stop their breath. Okay, when they stop their breath, they get more power to lift the weight. Okay, so in such conditions, whenever there's Valsalva maneuver, when you have to hold your breath, there will be increase in the intra-abdominal pressure. When there is increase in the intra-abdominal pressure, that will cause more compression over the aorta, inferior and superior vena cavas. When there is increase in the pressure there, that can lead to stopping of the blood flow to the peripheral muscles. When there is stopping of the blood flow to the peripheral muscles, the major muscles while exercising are our arm muscles. During exercise, when the blood flow is not getting to the muscles will go into anaerobic respiration, faster fatigue, and increase in the lactic acid production. Can also lead to sometimes heart attacks also. When there is sudden closure of the breath, the blood circulation is not again coming to the heart, and the heart will also not get good blood flow. And that can also again cause the heart attack. Clear?
Yes, ma'am. Thank you.
No problem. So I think we are clear with cardiac rehabilitation overall, which patients come into the picture, what are the different conditions, what are the different phases, and how you have to treat. Now we'll go to pulmonary rehabilitation. According to the ATS, which is an American Thoracic Society or European Respiratory Society pulmonary rehabilitation statement of 2013 states that a comprehensive intervention based on a thorough patient assessment followed by patient-tailored therapies that include but are not limited to exercise training, education, and behavior change. These are designed to improve the physical and the psychological condition of the people with chronic respiratory diseases to promote long term adherence and to improve the health enhancing behaviors. The major complaint what the patient comes is limitation in the work capacity in patients who have advanced lung diseases. It happens because of impaired gas exchange and alveolar ventilation. When there is less oxygen inside the blood, that leads to less oxygen supply to the skeletal muscle, that shifts to anaerobic metabolism. When there is a lot of anaerobic metabolism, there is too much of lactic acid production, and that leads to faster fatigue. Everyone clear? This is something which we have already discussed. So as there were core components in cardiac rehabilitation, there are core components in pulmonary rehabilitation also. So always the first thing is assessment. A detailed assessment has to be taken by any healthcare professional. Second is exercise testing. Third is field exercise testing if the patient is able to do or not. Fourth is quality of life measure. It can be done with the help of any scales like SF-36 or SF-18. There is dyspnea assessment. Dyspnea assessment has to be can be taken by MMRC scale, or it can be taken by modified box scale. Nutritional status evaluation has to be done by the dietitian. Occupational status evaluation is done by the occupational therapist. So imagine a patient has COPD and is working in a chemical factory. So occupational therapist will go to the factory, check the entire environment which is fit for the patient or not fit for the patient. If the patient is working inside the chemical plant and patient is having breathing difficulties, the occupational therapist should make sure that the entire setup is safe for the patient. If the patient is not safe, you have to shift the patient from the chemical plant to something like a desk job where the chemicals are not going to the lungs and the patient is more stable and can do the exercise as well. Then is endurance training and resistance training, which is a tab of the physical therapist, where with the endurance training, the muscles will work faster, will work for a very long time. With resistance training, there will be increase in the load of the mitochondria. The mitochondria will work better, and that can lead to aerobic respiration. Okay. With all these components, we have to create one nice program for the chronic lung patients for them to exercise well and improve the quality of life. So, for the patient assessment, you have to look into consideration all the components like musculoskeletal assessment, neurological assessment, cardiac assessment, vital measurements, blood tests, investigations, anxiety, depression, inhaler. Many of these chronic lung patients will be on inhalers or spacers or oxygen therapist or BiPAP or CPAP, and also if there are any comorbidities. So depends on the symptom. So suppose a pulmonary patient comes with a problem or is a patient of bronchiectasis, comes with a problem of too much of sputum production, and because of that the patient is very breathless. So depends on the symptom, I will choose the proper component. For such patient, I will use something called as airway clearance technique. In airway clearance technique, which will be working best if the patient is an adult, is very active, if the patient knows how to use, you can definitely go for the oscillatory PEP devices. Also, you can go for something called as ACBT, autogenic drainage. Okay. If the patient is cystic fibrosis patient and is a child of 10 years old, I will always go for a vest, which is a oscillating vest in such patients, because in cystic fibrosis, there will be too much cough production and the patient can get very tired. So the oscillating vest or PEP devices will definitely work better. Okay. So depends on the symptom. You have to change the component. If the patient is breathless, your main aim will be dyspnea relieving positions. If the patient has too much of cough production, LV clearance technique is the one. If you think that the patients have upper limb and lower limb strength less, you have to start with upper limb endurance training and strengthening training, and lower limb endurance and strength training. Such patients who have chronic lung diseases, you have to make sure that you manage their day very well. If you're managing their day very well, you're teaching them management strategies that will make sure that they are not getting tired faster, they are having adequate amount of oxygen for the entire day, and that will make them and their quality of life better. Everyone clear till now?
Yes.
Okay. So again, method of delivery. Method means you can start IPD, you can start with OPD, you can do telerehabilitation, you can also do home visit evaluation. So exercise training focuses on the endurance, strength training, and flexibility training. Cycling, walking exercises are the most common aerobic or endurance exercises. Frequency is 3 to 5 times per week according to the endurance training, and the intensity should be more than 60% of the maximal work rate or heart rate. And the time is 20 to 60 minutes. Always remember, whenever we are prescribing exercises, as you know, the doctors or the physician prescribe medicines, we prescribe exercises. It has to be done in a format of fit principle. What is a fit principle?
Frequency, intensity, time, and type.
Perfect. So every condition or every exercise what you give has to be in fit. So in endurance training, fit means frequency, means 3 to 5 times. I means intensity, which is 60%. T means type, which is endurance exercise, and time, which is 20 to 60 minutes. Then is interval training. It is one of the greater options for endurance training with people who have a lot of breathing difficulties. In intensity training, they have to do exercise for a very less time, and they can have enough break also, which will help to reduce their dyspnea and fatigue. Resistance training will help to improve the muscle mass and bone mineral density. According to the ACSM guidelines, it has to be done 1 to 3 sets for 8 to 12 repetitions, 2 to 3 days a week to improve the strength of upper limb and lower limb, and the amount of load will be 60 to 70% of 1 RM. Next is supplemental oxygen therapy. As I had already mentioned, people who have on chronic lung diseases where they have constant desaturation, in such patients, supplemental oxygen therapy while doing exercises is more beneficial because while doing exercise, we need oxygen. And when this oxygen is given, the patient is more stable and can do exercises very well. And patients who are very tired, or the patients who have lost their breathing because of too much of breathlessness, breathing retraining has to be taught, which is one of the most common training what we do is pursed lip breathing exercises, diaphragmatic breathing exercises. And patients who have a lot of oxygen desaturation, you can also start with thoracic expansion exercise. Again, with patients who have a lot of sputum production, cough removal technique or airway clearance technique is the most common. So this picture, what you're seeing, I've taken from one of the research articles. I think this research article was published in 2018 or 19. I'm not very sure. But this in that they have given a wide range of different options of airway clearance techniques. As you can see, one is proximal, one is peripheral. So according to your patient, your choice of airway clearance technique has to be chosen. For an example, if the patient is 3 years or 4 years of age and having cystic fibrosis, you will never give them ACBT or autogenic drainage because they will never understand the technique. For such patients, you have to go for oscillating vest or higher frequency chest wall oscillator. Patient who is around 10 to 15 years of age with bronchiectasis, you can definitely give them oscillating PEP devices. You can also teach them ACBT techniques. If the patient is adult, you can teach them ACBT technique, autogenic drainage technique, and also OPEP devices. If the patient is unconscious, is in ICU, and you see on auscultation they have a lot of cough or sputum, always go for positioning techniques and postural drainage techniques. Clear? So
Yeah.
every patient what comes to your OPD or IPD, you have to evaluate them. You have to see which technique is most suitable and most favorable for them. So now we'll just discuss 1, 2 cases for better understanding. First case is 62-year-old anorexic patient who has acute exacerbation of COPD, shortness of breath, increased work of breathing, and can't stop coughing and occasional phlegms, can't sleep and has fatigue, and is on 2 liters per minute of O2 with cannula, and while coughing presses the leg. So according to you, what is the condition the patient has?
COPD.
COPD, right? In COPD, according to the scenario, which type of COPD the patient has? Is it chronic bronchitis or emphysema?
Chronic bronchitis.
Okay, on what basis do you tell that? There's a very classical difference
Because
between
of
chronic. Tell.
because of just occasional phlegm, but a lot of coughing.
Coughing could be non-productive also. It's not compulsory. Occasional phlegms means they
Okay.
don't have too much cough production. I can just cough, but I cannot always have sputum, right? So there is a very classical difference between a chronic bronchitis and an emphysematic patients. In chronic bronchitis, there will be more cough production, less breathlessness. In emphysema patient, there will be too much shortness of breath and less cough production. In chronic bronchitis, the patients are little on a heavier side or are little healthier. In emphysema, the patients are anorexic. They are very thin. Okay. So this is a classical difference. So with this, we understand the patient as emphysema. Okay. So according to the condition, what is a problem list and how will you treat that? Anyone? What is a problem list? It's given right in front of you.
Shortness of breath.
Okay.
Uh,
What will you do for shortness of breath? Which treatment technique will you choose?
Endurance training.
For shortness of breath, you'll directly jump to endurance training? No.
no.
Patient will be very, very more shortness of breath. That will increase it.
For
Uh,
shortness of, we can
yeah,
give pursed breathing.
Perfect. Pursed breathing and dyspnea relieving rehabilitation. Perfect. Why pursed breathing? Because pursed breathing creates a positive pressure, and that positive pressure will help to keep your alveoli open for a very long time so that the air can come out. Okay. Pursed breathing, dyspnea relieving exercises. Perfect. Second, for constant occasional phlegms, okay, even if the cough is coming, what are the different techniques would you use?
like a clearing, something that clears it.
Yeah, airway clearance technique or ACBT. Correct. Okay. In that also one more thing is ACBT or vibration cabin given. Correct. Also one thing, fatigue. For fatigue, what will you do? For fatigue, what will be the goal or the line of management? So as you
Uh,
know, see, yeah, this patients will have very has less oxygen. Again, the muscles will not get enough oxygen. There will be fatigue. So the main thing you have to do is breathing retraining. Second, you have to start with upper limb and lower limb basic range of motion exercises. Make them more functional. More the functional, better. Then start with strengthening. Strengthening will help to increase the muscle mass. When there is increase in the muscle mass, there will be too much mitochondria in the muscles, and once there is a lot of mitochondria, there will be aerobic respiration and the oxygen carrying capacity of every muscle will get better. Clear?
Yes.
Please remember, in COPD patients who have acute exacerbation, never go for incentive spirometer. Please always remember, incentive spirometer is just making the patient more breathless and you're worsening the COPD more. Okay, already there is too much of air trapping. With incentive spirometer, the air trapping will keep increasing. For you, you have to focus on more of pursed breathing exercises and expiration exercises. And balloon bladder is one of the exercises which is important, is which we have to focus. If the patient is in a stable COPD or stable bronchial asthma, and if you feel that the air is less in the lungs, then you can start with incentive spirometer.
Ma'am, what
Clear?
about pulse breathing and diaphragmatic breathing?
Yeah, diaphragmatic breathing you can do, but with not deep breathing, with normal breathing.
First slip?
Pursed lip, yes, definitely. If the patient is breathless, you have to do pursed lip breathing exercise.
Okay. What about sleep pattern? Can we monitor? Should we monitor with sleep pattern, ma'am?
So sleep pattern is not in our hands. So there are sleep studies which are done. If you feel that many patients with COPD also have sleep apnea, you can definitely go ahead and speak to the pulmonologist and do the sleep study.
Okay. Thank you, ma'am.
Ma'am,
Okay,
can
no
you
problem.
repeat the one that you said for spirometer? What are the conditions
So there are
that you
two types of spirometer. One is one is volumetric and one is flow based. So specifically patients where you have to use incentive spirometers where the air entry is very less. Okay, specifically post surgery of the abdomen or post cardiac surgeries or post lung surgeries where there is a lung resection surgeries or any pleural effusion, pneumonia. In such conditions, inspiratory exercises have to be given. In COPD, already there is too much of air retention. We have to focus on expiratory exercises. Okay, did you understand the difference? Hello?
Yes, ma'am, I understand. I was just noting down the point. Sorry.
Ah, no problem. I hope everyone was clear with pulmonary and cardiac rehabilitation, with the conditions, with the types, the core components, the phases of rehabilitation, which kind of conditions what you use, and which kind of components what you use in different problems.
Ma'am, I wanted to
Everyone,
ask one doubt. Can you please
yes.
explain on JVP, ma'am?
I cannot hear you. What?
Jugular venous pressure, ma'am.
Yeah, jugular vein pressure. What is JVP, first of all? What is your understanding? घर पे है 3 है मेरी मम्मी लेकर आई मेरी मेरी मम्मी लेकर आई स्कूल okay, so jugular venous pressure. So jugular vein is one of the veins which is going side from our neck. Okay, so when the person has too much of increase in the right side of the heart pressure, there is a back pressure which goes to the jugular vein, which is towards the neck, and that increases the entire pressure on the jugular vein. When there is a too much of thickening or when there is too much of visibility of the jugular vein, that means that the right side of the heart is getting too much of pressure and the pulmonary system is also getting too much of fluid pressure. When there is too much of fluid pressure, that backflow increases the flow to the jugular vein and that leads to pulsating jugular vein, which is called as JVP. Okay, which is also one of the important assessment measures what you have to do when you are assessing any of these patients. And that will also tell you whether the person has any cardiac problem or pulmonary problem.
Thank you, ma'am.
No
Thank you,
problem.
ma'am.
I hope everyone was clear. Any difficulties?
No, ma'am.
Okay, thank you.